Cerebral blood flow versus function. Last week we sort of talked about how cerebral blood flow was one of those critical values that we use in medicine to sort of identify how much blood flow is going to the brain. Unfortunately, when you read this in the textbooks, this is more of a theoretical thing clinically because you don't really measure cerebral blood flow accurately in the clinical arena. Maybe in a few years down the road we'll be able to do that, but for now it's more of an interpretation of this idea that we sort of base on our clinical practice. Normally by studies we've shown that normal cerebral blood flow for most animals is around 45 to 50 milliliters per 100 grams of brain tissue per minute. Okay? And that provides usually the adequate amounts of nutrition and adequate amounts of oxygen as well as CO2 flushing during the system. Okay? The normal function can still be maintained at lower cerebral blood flow of about 20 to 45, so literally half the value without too much of a problem. And once you start getting below 20 cc's per 100 grams of tissue per minute, that's when you start beginning to see EEG slowing. Okay? So you're pretty far down the line if you're less than 50% cerebral blood flow before you even start noticing EEG slowing. Eventually, if you continue doing this, the actual sensory information coming back will actually become impeded. So your somatosensory evoked potentials, which is a form of study where we actually stimulate the skin, and then we see how it travels to the brain using like an EEG, will show that it's beginning to fail. Okay, so one of the things that you got to remember when you look at a BIS monitor, BIS monitors really basically look at electrical activity of the brain. So if you drop perfusion down, the BIS number will also fall, besides also how deep the anesthetic is. Okay? Depth of anesthesia will also suppress EEG activity, but also lack of perfusion will also do the same thing. And I'll give you a clinical example of how this is something you have to apply. We had an 82-year-old lady we were taking care of for hip surgery. And during the procedure, her blood pressure before we started was like 140 over 95. So we decided to keep her pressure up a little bit higher, like in the 110, 115 region during the case. Put her to sleep, no big deal. Intubated her, again, no big deal. And then I sort of inferred to the people I was working with and said, let's just, let's try to put a BIS monitor on her because, this lady is so much elderly. Let's see how minimum anesthetic we need to carry. We're sort of trying to teach the students, don't use a lot of isoflurane, which is, so they're down to 0.3 of isoflurane, which is nothing. It's like you're just pushing it across the, you could just get exposed to that yourself and it wouldn't do anything to you that much. But she was under general anesthesia with that, with a BIS value of around 25 to 30. So we actually had to back it down to 0.2 to get her BIS back up to around 40, which is where we need to be. So, and that's with 50% nitrous in addition. We could have done the case basically on nitrous oxide. It was pretty impressive. Okay? So this lady's running around 110 blood pressure, and then in the middle of the case she starts losing a little bit of blood. So the nurse anesthetist who was in the room did appropriately administer neosynephrine, okay, to bring the pressure back up. The heart rate was like 95. So with 100 mics of neosynephrine, the BIS value went to 0. Now that's pretty impressive. Okay? And you have to ask yourself, why did it go to 0? And immediately everybody said, well, our depths of anesthesia is too deep. And I said, no, it's the other reason. There's another reason for this, and that's lack of perfusion to the brain. Okay? And that's what we actually were seeing. We started giving her more fluids, got her blood pressure back up a little more, and all of a sudden the actual BIS values came back up in the 40s again. Now we decided to test our theory to see if it was anesthetically related at all, and we gave another 50 mics of neo at a lower dose, which is half the dose, and then we still saw that drop the BIS back to 0 very quickly again. So it was temporary, so we reversed it. But imagine if you would have put that person on neosynephrine drip. That one would have never woken up. Okay, so this is one of those things that sort of can infer to you that you have to understand this stuff. So when you get to clinical, it sort of makes sense. Okay? Now, if you continue compressing the cerebral blood flow enough that you're not getting any blood flow adequately, once you get down to 6 to 20 cc's per 100 grams of tissue, you have literally no cerebral function, okay? Not at least where you can actually get somebody to do what you needed them to do. You'll get, of course, extreme confusion up in the EEG slowing period, which is at 20 cc's. Most people will become combative and not really be able to talk to you appropriately. But once you're down to 6 to 20 cc's per 100 grams of tissue, then you're losing consciousness usually, and you don't really have any kind of significant motor response. If you maintain levels below down to 6 cc's per 100 grams of tissue, you have irreversible cell death, and you would get what's called apoptosis of the brain. Once that happens, you're not going to come back from it. So when you start taking this on to the next level, which is what do we actually measure? What do we know conceptually that we actually can monitor very well? There's basically three things that we can monitor very well that we know that affects brain function. Oxygen levels, okay? We know that we also can monitor CO2 levels. And the last one is mean arterial pressure, okay? So that's what we're going to do. We're going to try to apply this concept of cerebral blood flow by now extrapolating what we do clinically and then try to maintain a certain boundary of safety for the patient, okay? So the first one that we're going to discuss is autoregulation, which is control of cerebral blood flow via autoregulating the mean arterial pressure, okay? As long as the mean arterial pressure remains between 50 and 150 on a normal individual, note that under a normal individual, okay, cerebral blood flow remains at a constant rate, okay? So between 50 and 150, cerebral blood flow remains at a constant rate, which is the place where the brain's happy at, in other words, okay? Now, that waveform that's generated by this is basically a plateau phase during that between 50 and 150. So it's a constant cerebral blood flow, okay? Now, everybody in this room has a different plateau phase. Everybody in this room. So you'll see it on paper, but when you get to a patient, that actual plateau is different, and you don't know where it's at, okay? The important point of that is if you have somebody like who's hypertensive, okay, their plateau is going to be higher than yours because you're accustomed to the higher blood flow, okay? If you have somebody who is hypotensive or appears hypotensive all the time, but some people walk around with a blood pressure of 90, then that person is actually going to be at a lower plateau than you expect and do fine. Okay, but again, sometimes you just don't know where you're going to be at. Okay, so know that this is not a perfect science. It's more of an approximation of what you need to do. Now, if you get above 150 millimeters on your mean arterial pressure, then the normal autoregulatory system goes out of control, and the actual blood flow begins to increase dramatically to the point that you can actually get the blood flow to reach the microcapillaries or the capillary network in the brain and actually cause disruption. So you can actually cause hemorrhaging in the brain, which is devastating. Okay, so you don't want to go too high. And on the other hand, if you get below the 50 millimeter mark, then the brain, it gets inadequate perfusion, and then you're back to the point of now being underperfused and not have enough cerebral blood flow. Either place is bad. You want to sort of stay in the plateau phase. It's really the better place to be. Now, how this autoregulatory system is really established is most likely has to do with hydrogen ion concentrations. What's interesting about the brain is that the brain CSF is a very important substance that sort of helps maintain a certain degree of autoregulation of pH in the brain substance. Okay? But it's not as effective as the plasma CSF. I'm sorry, as a plasma in your blood. Okay? So when a person develops acidosis, okay, there's not enough proteins in the CSF to really basically buffer the acidosis effectively. Now the importance of that is that means that if you start getting acidotic in the brain, it persists for a longer period of time, but also because there's not much buffering capacity, the hydrogen ions rapidly change up and down, which basically activates the chemoreceptors much more rapidly. So in that sense, it's more sensitive to hydrogen ion concentration changes. Okay? Now, what you see is with autoregulation, is that under normal cell function, the surrounding cells tell that vasculature how to maintain its autoregulation. If you have areas of ischemia or of injury, the autoregulation pattern goes out of whack. Okay? It either goes into vasospasm inappropriately, okay, which a lot of you that worked in the ICUs, that were in neuro ICUs, what was the medication that you gave your patients all the time? Nimodipine, okay, which is a calcium channel blocker to prevent the smooth muscle from contracting and causing vasospasm that's inappropriate in that tissue. And other times, because the autoregulation is out of control, it vasodilates inappropriately, and you get higher perfusions to this area that's already injured, which can then steal the oxygen away from normal tissue. Now, this is the autoregulatory pathway here. This is what we normally put in books. I want you to do 2 addendums on your notes, okay? There's 2 portions of this curve, which I don't know why they don't show this in these books, but this portion of the curve is the other portion. So between here and here, this is 50, and this one's the 150. And you can see what happens to cerebral blood flow once you get above 150 millimeters of mercury. It starts going up, okay? So at this point, you can see that the blood vessels here have already vasoconstricted down to a very small level. After this point, the blood vessels begin to dilate again. Okay, and that's what causes the perfusion, increased perfusion to the brain in that area, which then can cause the shearing effect on the capillaries. Now, the autoregulation system this is the normal plateau that you should see. Okay, but you do have certain diseases where a patient loses autoregulation. Okay, patients that are chronically hypertensive can sometimes lose their autoregulation completely and not even really have a plateau phase. Okay? You have certain medications that may also affect the brain, and they start losing the autoregulation mechanism as well. Okay? The downside of losing the autoregulation is that it's a linear slope. Okay? So any kind of change in blood pressure can immediately have effects on cerebral blood flow, either in a positive or a negative fashion. Okay? If you can imagine that this area is a autoregulation area for a injured brain, if you increase perfusion, let's say to this point here, and we'll make it this point here, and you went from here to here versus here to here. Okay? In the normal tissue, the brain hasn't changed the cerebral blood flow at all. Versus in the abnormal portion of the brain, the cerebral blood flow is actually increased dramatically, okay? Which then can cause more extensive injury into that tissue. And then it may also begin to shunt the oxygenated portion of the blood away from the tissue, the good tissue, and goes to the dead tissue. And so you can actually do what's called a steal maneuver, okay, which is something that you really don't want to have. Now, the other mechanism that we also know that controls cerebral blood flow is CO2. The importance of knowing this is that it's a linear relationship related with CO2 and cerebral blood flow. So that means on the operating room, we can rapidly correct or change the CO2 by altering minute ventilation, and as a consequence, alter cerebral blood flow, which ultimately can affect intracranial pressure. If you have a patient who is, let's say, has a very tight brain, the surgeon will request from you to basically untighten the brain by hyperventilating the patient. And that works actually very effectively, and you can actually visually see these changes occur as you begin to hyperventilate. Okay? Usually when you see for every 1 cc cerebral blood flow increases for every 2 millimeter rise in CO2, the reverse is also true, which is for every drops in 2 millimeters of mercury, they would drop in 1 cc of cerebral blood flow. What you end up seeing is this curve is what you generate. Okay, this CO2 curve is a very linear fashion. Notice that there are the danger points here. At this point, the line should be drawn like this. Okay, which should indicate that cerebral blood flow goes to 0, which it does. Okay, if you ever want to try this experiment, I don't recommend it because you won't feel well. Okay. Try to hyperventilate for a few minutes, okay? And pretty soon you're going to be on the ground. Okay? You're going to get dizzy, you're not going to feel well, and most people are just going to lay down and say, I'm not doing that anymore, okay? And what you've done is if you actually hyperventilate while you're awake, and you're not, you haven't acclimatized to that, as soon as you reach a CO2 around 25, you start getting symptoms of hypoperfusion to your brain. You'll say to yourself pretty quickly, I don't feel very good. Okay? So the same thing happens with somebody in the operating room, but they're asleep, and they're able to tolerate this a little bit better because the anesthetic actually protects the brain. That's why we use isoflurane so much, okay? Because we find actually isoflurane uncouples the cerebral metabolic rate of oxygen and also protects the brain. So if you have to pick a choice of which volatile anesthetic to use in neuro anesthesia, the answer is always isoflurane, at least up to this date. Now, the other thing that also alters cerebral blood flow is oxygen tension, and it really doesn't really matter all that much as long as you're over 50 millimeters of mercury. So as long as you're above that, the actual cerebral blood flow stays unaltered. Okay? But once you get below 50, cerebral blood flow continues to significantly rise. So if you're really concerned about ICP pressures, you should supplement and give that patient additional amounts of oxygen so their TOR of PaO2 is above 50. There is basically a 10% reduction in cerebral blood flow if PaO2 is over 500, but that's almost something you never see. You can try to do that in clinical situations with giving somebody 100% FiO2. Usually, though, if somebody has that degree of brain injury, they've also suffered some degree of lung contusion, so usually it doesn't last very long, and eventually you're going to worsen the lung injury from using high levels of FiO2 like that. So just be careful with that. Temperature is directly related to activity. So if somebody is burning up, it's smart to try to get their temperature back down as your cerebral blood flow increases dramatically in this kind of situation. Some of the thoughts in the old days was actually keep somebody very, very cold, and we're actually going back to it again. Okay? In medicine, there's nothing, you think you've learned something new, and you haven't. Okay? Human beings have known a lot of things about medicine for thousands of years, but it just seems to go in and out of a context in how we do things. We know that brain activity is significantly improved in its survivability with cold, and now in the ICUs we're actually inducing hypothermia in patients that have had codes with better brain survivability. So this also has to relate to this as well. With cerebral blood flow, you see a decrease in activity because the cerebral metabolic rate of oxygen consumption drops off as the temperature drops, so the cerebral blood flow linearly correlates with that. And this is what you see. This is the cerebral metabolic rate of oxygen consumption, okay? And you can see how as the temperature drops, okay, down to around 17 degrees is the magic number, you get no brain activity at all, okay? Now, the reason that's so important is, let's say you have to do an open heart case where you're going to do cardiac standstill, and you're not going to be able to put that person on bypass run, then with the temperature we try to go to is around 17 to 19 degrees to basically protect the whole brain. Okay? We shut down the brain so much so that now that person is basically in an induced coma and actually can protect the brain for prolonged periods of time, as much as 35 to 50 minutes, and the patient still do wake up pretty normal. Other things that control intracranial contents and brain volumes, the total volume in your brain is around 1,200 to 1,600 cc's. So that's not a lot of volume. It decreases volume from atrophy. You can cause significant brain tissue volume decreases from dehydration. Patients, of course, have had resections. Diuretics also can significantly decrease the volume. The biggest enemy to us is because the brain is an enclosed inside the skull, which is a rigid structure. Tumor and edema, which are both, one's a space-occupying lesion and the other one is actually due to excessive fluid in the interstitial space around the brain, will cause possibilities of herniation and rapid increases in intracranial pressure. The other thing that increases your intracranial contents, of course, is the CSF. CSF is a smaller amount of volume, but it's still greater than blood. The actual normal volume is 120 to 150 cc's being produced by the choroid plexus, which we talked about before. The actual rate of production is an important value, which you should know that one, is at 0.35 cc's per minute. Okay? It basically causes the CSF in your brain and surrounding spinal cord to basically alter itself 3 times a day. If you have 150 cc's, okay, in your brain, by the time your brain has switched over by the day, I think it's like 500 cc's per day. Okay, so it flips it out. So you got 3-fold change. Okay, 3 times 5. Yeah, it's about that. 450 to 500 is what the numbers usually say. Absorption takes place via the arachnoid villi and the spinal venous plexi, but the majority of it is via the arachnoid villi and the superior sagittal sinus of the brain, okay, which is part of the venous system of the brain. Okay, but there's no direct connection. In other words, CSF and blood don't mix. It would be abnormal to see blood mixed in with CSF. Normally, the absorption rate is equal to the rate of production, which is why you have a steady state situation. Now, again, the question is, why do you have this? Why not just have a constant fluid? Why do we keep changing it? It filters out the junk. Okay, the cells drop bad stuff into the CSF when they want to get rid of stuff that they can't really get rid of any other way. The other thing that CSF, of course, is a buffer. Okay, so it's not as good a buffer as plasma, but it still acts as a buffer. So you have to keep that replenished and changing out constantly to make sure that you're not causing great changes in acid-base status. So this is a normal motion. You see the motion of CSF productions in the choroid plexus, which is located in the lateral ventricles, which I call ventricle 1 and 2, and the third ventricle. And then it distributes downwards, going down to the spinal cord, and then comes back up, even around the eye, and coming back, and then goes back up to the arachnoid villi in the superior sagittal sinus, where it gets reabsorbed. Notice something really nice about this picture. Okay, there is only one place where you can actually graduate, which means that you can actually see how much CSF is in your brain. Okay, and actually the only place you can actually see it is in the eye. Okay. Now, why is that important? Okay, clinically, if you have somebody come up to you and tell you, look, this gentleman has papilledema. See this word right here? Papilledema. That's a critical word to know. Okay, it should send little alarm bells all over your head. Okay, that means that person's, when you look at this person's eye under direct fundoscopic evaluation, okay, the actual optic disc that's behind there should appear fairly flat. Okay, you should be able to see the artery come in, and it goes over a ridge. Okay, that ridge is where the actual CSF is pushing on the back of the eye. Okay, normally that should be under 1 or less diopters, which means it's almost normal. They should see it clearly. When you get papilledema, that ridge gets pushed forward. Okay, and if you're looking at something stereoscopically, which means that you're looking at it from above, okay, in this case you're looking straight into the eye, but if you're looking at stereoscopic substance, things like a mountain, if it's at a different height, what happens to the image? The one that's closer to you if you're looking at the bottom. It looks out of focus. You can't focus on it. Okay, the top will look weird because the glass that's looking through it can only see a certain range. Okay, so that's called a diopter. How many diopters you have to switch to get focused again, okay, will tell you the degree of papilledema. Okay, so if you have somebody which has significant amount of papilledema, that distance of that ridge gets high enough that it becomes a mountain. Okay, and that's a bad sign because it indicates a very high intracranial pressure. The importance to you is that if you're told this, you cannot do any kind of regional anesthesia that's a neuroaxial anesthetic at that point. Okay? If you do, and if you decide that you're going to do this, you're going to cause a catastrophic event. Okay? If you put a spinal in that person, the CSF will squirt out with so much force, and it will basically, even when you pull the needle out, will express itself out that hole so fast that the person will herniate in front of you and die. Okay? So with papilledema, you never do this. It's not something that's appropriate to do. Okay? If you do an epidural, the devastating part of that is if you stay in the dura, no problem. But above in the epidural space, no problem. But if you penetrate in the dura, that's a heck of a bigger hole than a spinal, and it's going to be over in seconds instead of maybe a minute or two. Okay, so you don't play this game. Okay, if you hear somebody say papilledema, that answer is don't do regional anesthesia that's involving the spine in that patient. Okay. Now, the CSF rotates in your cavities, okay, from the choroid plexus all the way down to the spinal cord. And you just imagine my CSF that's in my caudal area right now, when I'm not as far as that, but in the L1, L2 region, okay, has to come all the way back up to my brain. And you have to ask yourself, how does it do that? And the way it does it basically is two ways. There's a certain degree of pulsations, but that's really a minor factor, which is if you look, when you actually put a needle in somebody's back and do a spinal on them, okay, we hook it up to a manometer, okay, so we can actually see the fluid level. And you can see every time the fluid level, you can see it literally bouncing a little bit every time the heart beats. So the heart actually has a pulsatile effect on CSF. So you would say, well, that's the reason that CSF rotates, right? And that's why it has motion. But then I give you the option of saying, ask the patient to take in a breath, okay? And when the patient takes a breath, the CSF will drop by 4 to 5 millimeters, okay? Which is a significant drop, okay? And then we tell them to breathe out, and then it goes above the level you're at. So there's a huge amount of fluctuation, not from the pulsations of the heart, but it's really from breathing, which kind of makes sense, because when you start thinking about what you do in regional anesthesia, and this is why I'm sorry giving this to you at the last minute, okay? So I'm trying to incorporate all the stuff in your mind, okay? When you do an epidural on somebody, where does the fluid go when you inject it? You should have this in the back of your mind already. What percentage of the fluid that you inject in the epidural space, where does it go? Nobody knows? 70% goes to the brain, towards the brain. Doesn't matter your position at all. You could be sitting up and it'll still ascend 70%. And you have to ask yourself, why? Okay? Because even though the epidural space is not connected up to the CSF, it is connected to the same column of negative pressure in your chest. So as long as you're spontaneously breathing, when you take in a big deep breath, the fluid gets sucked upwards, and that's why you get a more cephalad spread with an epidural. Okay? Now, again, what's interesting about that too, okay, is if you take a person and put them on positive pressure ventilation, what do you think the CSF spread's going to mean? What do you think the epidural spread's going to be in that situation? Is it going to come up? No. It distributes into a 50-50 pattern. 50% goes down, 50% goes up. So you don't get as high level, which is, again, understanding the physiology of what actually is taking place in the column. Now, when you hear about that the person has negative pressure inside their epidural space, again, this has to be correlated to the reality that that column is connected up to your chest. And that's why you have that negative pressure. Okay, so if you don't believe this, when you put an epidural, listen carefully. Okay? If when you put the epidural in and you disconnect your syringe and the person takes a big deep breath on you, okay, you'll hear a little sucking sound coming through the needle. Yep. Positive pressure would put positive pressure in your chest. Okay? So that doesn't generate the negative suctioning of pulling the fluid up. So it acts like a dam and holds the pressure inside your epidural space as positive now, and your spread does not go as appropriately as you want. Okay? A lot of clinicians don't know that, and when they administer the drug at the end of the case, the blood pressure doesn't drop, okay, which we'll talk about in spinal cord injury later on, because the epidural doesn't ascend that much. Okay? But as soon as they shut the ventilator on, the person's spontaneously breathing, then all of a sudden the blood pressure drops like a stone, and they don't understand why. The reason it happened was because all of a sudden, as soon as you stop the positive pressure ventilation, that fluid is stacking down there. And if you gave too much of it, because you didn't get the response you wanted, as soon as you switch them back to spontaneous breathing, that fluid comes up rapidly and knocks out the autonomics. And now you've got hypotension in your hands. Okay? So all this stuff, you got to understand it before you start using it. Okay, CSF its production is increased by hyperthermia. If you do a cervical sympathectomy, you also will cause an increase in CSF production. Low serum osmolarity, drugs like enflurane and halothane are older drugs, but they do increase CSF production, and that is contraindicates them to use in brains that are tight. Think about it. Okay, if you don't want the brain to get any tighter, why would you want somebody to produce more CSF? So this is the drugs that you want to avoid. On the other hand, if you have somebody who has spinal, and you know they have a post-dural puncture headache, and you have to put them under general anesthesia, I would turn on halothane and enflurane in that kind of person to increase CSF production, maybe help me repackage this person's CSF before they wake up, besides giving fluids. The other thing that increases CSF production is some kind of functioning tumors. Decrease in CSF production will be things like hypothermia. So anything that decreases the metabolic rate of the cells would obviously decrease CSF production. Drugs like acetylcholine, okay, high osmolarity, raised ICP also inhibits the transfer across of CSF, and steroids as well. The effects of anesthetic agents on intracranial volume, the actual cerebral blood flow, anesthetics generally reduce cerebral activity and cerebral metabolic rate of oxygen. Inhalational agents all cause an increase in cerebral blood flow, cerebral blood volume, and ICP. Okay? So that's a bad side to them. Okay? They all increase cerebral blood flow, cerebral blood volume, and ICP. They do decrease cerebral metabolic rate of oxygen consumption, though. So that's a what? It's a disconnect. You're disconnecting one system from the other. Okay? The downside to all the volatiles is they do increase cerebral blood volume, which means that ICP pressures are going to go up. Okay? Now, obviously, you can see that's a test question. If that doesn't sort of jump out at you, it's like, geez, you know, he's got that's three, like that looks like a multiple choice question. Hello? Okay? And that's a very favorite question they ask on the board, so that's why I put it that way. IV agents tend to reduce cerebral blood flow, cerebral blood volume, and ICP. And they also decrease cerebral metabolic rate of oxygen consumption. So which one's a better agent to use in somebody who's brain injured? IV anesthetics. They tend to be better. Okay? That's why we put patients on not a isoflurane coma. We put them in a barbiturate coma. Okay? That's why we do that. Okay? Reactivity to CO2 is not abolished by inhalational agents, which is kind of a good thing. The effects of CSF that's detrimental is halothane and enflurane. And this is the second slide I've read that said this on. So again, I'm not sure how important it's going to be on your boards because these medications are sort of going out of use, and maybe another year or two I can delete it from my slides because almost nobody has these anymore. Where you might see these is if you go to missions, like in Haiti or other places, they still have halothane in great abundance because it's one of the cheaper drugs available out there. So what do you do? What happens if somebody has a tight brain? What are the different things you can do? Well, one thing you can do is you can decrease CSF volume. Okay, you can do this by putting an ICP drain. Okay, or you can induce it by giving an IV anesthetic agents such as either propofol or barbiturates to decrease metabolism, which increases the oxygen availability. So this is the different kinds of systems that you can have that you can use. Mannitol can also be used to sort of diurese the brain. Just look this over. It's more of an idea for you how you actually can manage different situations. Pharmacologically, hypnotics and sedatives depress the central nervous system in a dose-dependent manner. The benzodiazepines moderately reduce cerebral blood flow and cerebral metabolic rate of oxygen consumption. And they're safe to administer to patients with elevated ICP, and that's why we use them in the ICU. And treat respiratory depression, which is the biggest problem with them. and avoid hypercapnia. The last thing you want to do is give these agents without a secure airway with good control of breathing, because if they start increasing their CO2 levels, you basically offset all the benefits of these medications. It is really contraindicated to give these people flumazenil. Flumazenil will definitely increase ICP pressures very rapidly, and you may actually cause somebody to herniate. So in other words, you never reverse these drugs, okay, if you have a tight brain. Okay? It's really not a good idea. Pharmacologically, opiates do not, unfortunately, have any effects on GABA. Okay? GABA is what actually is an agonist that suppresses the brain. So if you don't have any kind of GABA activity, that patient's going to have total awareness and be very awake. Okay? Now, they will appear to be asleep, okay, if they're getting opiate receptors such as mu receptor binding, okay, which acts as a normal, endogenous medication that's in your body that are like opiate-like receptors. Okay? So the good thing is that opioids have very little effect on cerebral blood flow in ICP, but their indirect actions is where they get their bad side to them. Okay? Because mu receptors in humans actually suppress the actual brainstem to breathing. So minute ventilation drops off, and the person then gets an increase in their ICP pressures that way. But fentanyl by itself, if you're controlling minute ventilation, has no effect on cerebral blood flow at all, or ICP pressures, okay, which makes it a useful drug in certain situations. Okay? Fentanyl and morphine, actually we should change this completely, because we're not allowed to use any kind of abbreviations anymore, so we're actually going away. We have to write everything by hand. So morphine sulfate, which is MSO4, is now something that you don't use anymore, so I have to write it out. Morphine and Demerol really have no effect on cerebral blood flow in ICP. Fentanyl and alfentanil, which are the modern narcotics and synthetic narcotics, can actually have moderate reductions in cerebral blood flow. They do have significant reductions in cerebral metabolic rate of oxygen consumption. As a consequence, will actually reduce ICP pressures. Now, sufentanil, on the other hand, has a controversial side of it. I don't particularly like sufentanil because I call it the super puke drug. Okay? Anytime I use sufentanil, as soon as the patient got to recovery room, they horizontally vomited across the room. The nurses always knew when I did it, and they weren't real happy with me. Okay? They would start yelling at me and say, "Don't give that drug anymore." I said, "Well, I'm trying it out." I said, "Don't do it anymore." So, and this is before the age of Zofran, so you can imagine. So we found out sufentanil is a great drug for pain, but it is a very potent nausea-producing medication. The other problem with it, too, is that associated with it is that nausea is an activation. It's telling you that the brain is getting activated by it. And some people actually believe that it increases ICP pressures from the increased cerebral blood flow to that portion of the brain. So sufentanil is kind of controversial if you should use it. But if you have somebody who's vomiting, what's happening to their ICP pressures? I can assure you it's going straight to the roof. So for that reason alone, I'd stay away from it. Okay? The IV anesthetic induction agents are all fairly safe except for ketamine. And ketamine has mostly to do with because of the increased cerebral metabolic rate of oxygen consumption, as well as the other big problem, which is increase of sympathetic discharge, which can then rapidly increase your ICP pressures. Inhalational agents, which we talked about before, halothane, enflurane, isoflurane, SIVO, desflurane, and nitrous oxide. The one that has the most protective effects in the brain is going to be isoflurane. Okay? It does disconnect it, but it has less of an effect, and it's actually been found to be protective of the brain. The exact mechanism has not been elucidated completely, but it's not like isoflurane increases CSF production like halothane or enflurane. The other anesthetics have really, the SIVO and desflurane, have really not been adequately worked up to really tell you if it's safe to use. Some of the newer studies are starting to show that they are okay to use, and some books are actually beginning to say that desflurane may actually be the one of choice. The problem with that is really that desflurane does not do much more than 1 Mac. The only thing you can reach with desflurane is 1 Mac. Versus this one, you can go to as much as 4 Mac. Huge difference. Okay? If you get above 1 Mac of desferrine, you're going to have to start adding a lot of narcotics. Okay? If you need more than that to hold that person down. Okay? The reason that is because above 1 Mac, you get severe tachycardia with desferrine. Okay? So you have to sort of avoid that. So above the Mac, which is 6, you really shouldn't be above that. So your desferrine is going to be initially at around 7 or 8 if you want to, until the level gets up to around 6, but don't let it sit be above 6 on your expired fraction, because you're going to find out real quick why they're getting tachycardic. And if the student doesn't know this, what will happen is you'll keep cranking up the desferrine, thinking like, the patient's light, and you're just making the situation worse. Okay? Some people are very, very sensitive to desferrine, and I've walked into rooms where the heart rate's already 120, and everybody's sort of freaking out, and I said, you know what? Shut off the desferrine, open up the forane, okay, and said, now watch what happens. Heart rate comes back down to 80, patient goes being happy again, okay. So not every drug works for every patient, okay. As to why that person it tends to be seen in younger people. They're much more sensitive to desferrine than older people. So just, you got to start, you're seeing your different populations. Yes? Mac to Mac. No, you shut off. You can only have one anesthetic volatile at a time. The throw arm in the back of it will not allow you to open up 2 volatiles at the same time, which is really good because, you know, it avoids mistakes. Okay, so you got to shut it all the way off. Just know the value you're at. Convert that in your mind to Mac. Okay. So if I tell you that I'm at a Mac of desferrine, that means that I'm at 6 Mac, 6% desferrine. The equivalent to that in isoflurane is 1.15. Okay, so what I do is I'd shut off the desferrine and switch them over to 1.15 on the isoflurane. Okay, so whatever the Mac value is, I try to correlate it. Okay, and as one goes off, the other one will come on board. There's a slight difference in slope, and we can hit all that stuff at a different time, but that's more of a technical answer. Muscle relaxants, succinylcholine does increase ICP pressure, so please understand that it does do that. But everything in life is a but, okay? Because what happens is ICP pressures take a back seat when it comes to the airway, okay? If you have a difficult airway in your hands and you have a possibility that you need to get this person intubated quickly because they have a full stomach, then succinylcholine is perfectly indicated. Okay, where it's to be contraindicated to somebody who has, you know, prolonged denervation injury or something like that, that'd not be appropriate, or spinal cord injury more than 24 hours. All those things would be contraindicated because they get hyperkalemic arrest, not because of the ICP problems. Okay, it's nothing worse than watching somebody trying to ventilate somebody who's difficult, okay, and they're waiting for the muscle relaxant to kick on board, and then what's that doing to ICP pressures? If you can't ventilate efficiently, what's happening to CO2? It's rapidly rising on you, so that's worsening the situation. So don't shoot yourself in the foot. Okay, just realize that succinylcholine is going to increase ICP transiently, but it's transient. Okay, if the person is not going to tolerate from the medication that increase in ICP, what's a maneuver you're going to be doing here in a second that's really going to raise their ICP pressures? Laryngoscopy. You're putting a big blade into somebody's mouth. You think that's going to be nice and wonderful? Okay? That's going to hurt. Okay? So that's going to drive your ICP pressures up even faster than any drug that you're administering. Okay? So I'd still consider succinylcholine as my first-line agent in many, many situations, and it keeps me out of trouble. The people that use non-depolarizers are factual in the sense that it has no effect on ICP pressures, but they're not giving you the full picture because they're not telling you that laryngoscopy is still going to raise ICP pressures. You can almost avoid that. Okay? If you get histamine releasers, then you can cause an ICP increase. So giving atracurium, if you're the one that's worrying about ICP pressures, then you can't give atracurium. You got to go with something like vecuronium or what was the other one named? Rocuronium. Those are the ones that you would tend to use. You'd use more of the aminosteroidal non-depolarizers instead of the benzoyl isoquinolones. Diuretics, of course, mannitol is a first-line agent used very often. It's an osmolar therapeutic agent of choice in reducing ICP pressures. It has a fairly quick onset of 10 minutes, and it removes water from normal and not edematous brain. The bad thing about mannitol is that if you have a disrupted blood-brain barrier, mannitol will penetrate into the brain tissue and actually act like a sink to pull water into it. So brain that's already injured is maybe not a wise idea to use mannitol. The problem is, when do you know if somebody's brain is really significantly injured? So, and it becomes where it's chicken like the egg argument. You know, you don't know where should you know, what kind of therapeutic maneuver do you do in some situations. And unfortunately, the best answer I can give you is experience. And that means you're flying by the seat of your pants. When people tell you that it's experience, okay, you're guessing 90% of the time, and you might be accurate 60% of the time if you have a good experience, okay? So be careful when people tell you, oh, it's just experience, okay? It starts lying in the part of art, which requires a lot of time, and that means when you do a lot of time, that means what? A lot of errors, okay? And you don't know who you're erring on. In essence, you're trying to make the best decision you can, but you're maybe making errors that you just can't, you don't have any control over. There's not enough data to give you the right therapeutic agent to use. Be very careful with mannitol, especially with patients with congestive heart failure. The downside of mannitol is that around 6 hours you get this what's called rebound hypertension effect. Intracranial hypertension effect may occur and may actually cause more edema to form. Large doses of rapid infusions may also cause a rapid rise in ICP pressures. That's why we tell you to give mannitol kind of slowly. Most of us will give it as a drip instead of a bolus fashion. Loop diuretics are very useful for the brain most of the time. It's pretty safer to use, okay? It decreases CSF production, and it lowers ICP without increasing intravascular volume or blood osmolality. Its slower onset of action also gives it a little bit more time for the brain to sort of adjust. Usually in 40 minutes is the maximum effect. And it significantly potentiates the action of mannitol. The downside to it is it takes too long in the operating room, okay? So what we do is we give combinations of mannitol and follow it with Lasix for a prolonged duration effect to decrease ICP pressures. Okay? That's how we do it. Okay? So mannitol is usually the first-line agent. If after hyperventilation is not adequate, we give mannitol very quickly to get that ICP pressure back down. Okay? Again, don't give it as bolus, but give it more in a more gradual effect so you don't get that rebound effect with mannitol. Vasodilators, systemic vasodilators, unfortunately, all increase ICP pressures literally by increasing cerebral blood flow to the brain. So maybe it's not a good idea. Things like nitroprusside, nitroglycerin, and hydralazine, all are cerebral vasodilators and all subsequently cause an increase in intracranial pressure. The only thing that's very effective, and they used to be used a lot, were ganglionic blocking agents such as trimethoprim, which causes less of an increase in cerebral blood flow in ICP. The downside to this drug is that it causes mydriasis, so the patient looks like they herniated. That's not really something that you want to see, you know. And cycloplegia. Beta blockers, on the other hand, have minimal effect on cerebral blood flow in ICP, and this is our drug of choice. We tend to give a heck of a lot of esmolol in neuro cases, as well as labetalol. Okay, labetalol has some effects because it has an alpha component to it of vasodilating, but in comparison to everything else we have, labetalol tends to be a more of a protective effect because more of its beta action. Vasopressors have minimal effect on undamaged brain unless you have a person with a disrupted autoregulatory mechanism, which is what I was talking to you about, that lady that was 80 years old. She was linearly correlated to how much vasopressor was on board. So something like alpha-1 agonists such as phenylephrine may actually significantly decrease cerebral blood flow dramatically, which has no effect on cerebral metabolic rate of oxygen consumption, and that means an uncoupling in a very wrong way. If you have no change in cerebral metabolic rate of oxygen consumption, but your cerebral blood flow all of a sudden drops off, then you're starving the brain of oxygen that it needs. Okay? And as a consequence, you get significant injury. Norepinephrine may also cause vasodilation if the blood-brain barrier is actually damaged, so you may actually have the detrimental effect on the reverse side of it. So levofed may not be the best choice in a lot of situations, as well as Neo. Epinephrine maintains a normal cerebral vasculature. It has really no effect. But if the blood-brain barrier is damaged, the epinephrine will cross over an increased cerebral blood flow and cerebral metabolic rate of oxygen consumption. It goes up in linear fashion, so it goes in more one-to-one basis. It's not uncoupled, so in essence, epinephrine is still kind of protective of the brain. The only downside to it is that, of course, it can increase ICP pressures. Dopamine has little or no effect. At high doses may actually begin causing alpha-mediated vasoconstriction, but then you're up at the 10 mics per kilo per minute level, which is pretty high. So, try to avoid that kind of drug. Yep. We tend to use, depends on what you believe in, okay? Some of the new studies have shown that the brain is starving for oxygen in the injured area of the brain. Okay, so some people have believed for a while that they want to increase blood flow to the brain, not decrease it. Okay, in the old days, we used to decrease cerebral blood flow a lot, and I think that was very detrimental. It would be beneficial for your ICP pressures for a little bit, for about 6 hours. Then your ICP pressures would start climbing again, and then you'd try to drop it again. So you would be, and eventually you had a dead patient. What you were doing, is we think we were doing, is we were cycling the patient into ischemia, okay, by dropping cerebral blood flow. So the other side of the field decided to argue, hey, look, let's hyperperfuse the brain. Let's crank it up, okay? Let's increase perfusion and really try to keep enough oxygen so the surrounding tissue doesn't get compressed and get edematous. And the downside to that way of doing it is that you drive the pressure up so high that you start pushing fluid into the into the interstitial space and cause a little bit more edema to form. Which side's right? Most likely it's somewhere in between. Okay, I think that the people that drop the pressure is not a good idea. So most of us will try to maintain blood pressure to the brain to be adequate. The way we do it is we don't give vasopressors, which don't really work. Okay, vasopressors, all they're going to do is they're going to vasoconstrict the brain, and it's not going to help perfusion to the brain. Instead, we tend to increase the heart activity. So we'll bump the heart by increasing its contractility and still maintain cerebral vasodilation if the ICP pressures are not rising. So what would be a good drug to use for that situation? Dobutamine. Dobutamine tends to be a good choice in a lot of these situations. So a lot of neuro ICU units will use dobutamine extensively. Okay. I've personally done some experiments where we actually, we're trying to measure cerebral blood flow of the brain, and we would put in catheters, central lines in the internal jugular vein, but we thread it up to the brain. So we actually put the central lines upside down, okay? And then we would draw blood off, and then we got really smart. This was in the 80s, early 90s, okay? We would put an SVO2 catheter in, and we would measure the actual venous oxygen saturation coming out of the brain. Unfortunately, we couldn't demonstrate that it was improving the brain. It was giving you more of a global phenomenon. In other words, it was taking all the hemispheric venous return from this side. It would be draining on this side, but it would not tell you of a small focal area that was ischemic. So we couldn't demonstrate that by altering blood flow could we change the outcome. And the answer is really no. What you're doing, though, is you're trying to prevent the low SVO2 coming out. And that was kind of nice because we learned that, hey, it's better to perfuse than underperfuse. And one of those things that you can extract from looking at those studies is that people that underperfusing, the SVO2 was very, very low. Okay? And that means the extraction rate for the brain is very high, and there's no extra. Okay, so when the SVO2 is coming out, it means a lot of the oxygen has been pulled away. And if you have an area that's really not being adequately perfused, that portion of the brain is starving for oxygen and dying. So we would maintain a higher SVO2s, and it seemed like people tended to do better. Okay, but still, you're talking about brain, and if you're looking at how much we actually understand, it's a joke. Okay, we really don't. Okay, and we don't even understand how much of the brain can you tolerate being damaged. I can tell you one thing. Whatever you do to the brain, if you injure it, you're not going to be the person you were before. Okay, I don't care what anybody says. Okay, there's something different about you. Okay, because you use every single portion of the brain. They're doing, I think, a big disservice by telling people that this congressman is going to do really well. Okay, they're not telling the people the truth. okay, the person's going to survive and may actually be functional, but she's never going to be like she was before. So people have to understand that, and you have to tell that to the family so they can be ready and begin to understand and not feel cheated by the medical personnel by being told something different. Okay? To be told that everything's going to be great and fine, it's not. It's going to take a year. You're going to have a little kid in your hands again, and you're going to have to teach him all the way back to the level that you want him to be functional again. Now, the great thing about knowing is that the plasticity of the brain is tremendous. Okay? The amount that you can relearn is amazing. Okay? If you have somebody who loves you and cares for you, and you have professionals that are pushing you all the time. The idea of taking somebody who is brain injured, okay, and putting him in what we call them cactus farms, and depending on which part of the country, it was either called a cactus farm or a vegetable garden, whatever else. It was horrible. All the things that people would call. Okay, I tell you, I'm a medical professional. I know what it's like. It's very hard having to take care of people in the ICU. You know they're severely brain injured, and you can't do anything for them. But you know that if you send them somewhere, instead of farming them to a floor and just let them sit there with nobody stimulating them, you're going to have nothing. Okay? Versus you have somebody who's on top of them every day, talking to them, reading them a book every day. It starts reconnecting the neurons. Okay? And then you're going to have somebody refunctional again. Is that person going to be the same as you were before? The answer is absolutely not. Okay? But you are going to have possibly a functional individual. The problem we still have is we don't know what is the optimal amount of stimulation that somebody needs for how long, and how do you know how their outcome is going to be. And again, all that stuff we don't know. Okay, so this is an area where there's a lot of research still needs to be done. The actual critical portions of getting them to survive to the next phase is what we try to do. Okay? But the therapeutic portion, which is really going to make the functional element of that human being, is something that's outside of our field of scope of practice. Okay? But your job is to keep them alive long enough to hopefully get them to the next phase. Okay? Never, never quit. Okay? If you're a true believer, like I am, okay, that you never quit on somebody. Okay? I can tell you though, it's hard sometimes watching the end result. Sometimes you actually end up feeling a little guilty for not quitting sometimes. Okay? But again, it's their life, and they can do the best they can out of it. You're giving them that option to survive. Okay? Now, would some people argue in their family that it was a good thing? Some people would say no. Some people would say yes. And different family members would tell you different things. Okay? So again, our job is to give that person an optimal choice of survival, and that's why we're teaching all these basics in physiology and anesthetic maneuvers that we have. Okay? Any questions?